I think that targeted therapies and immunotherapies are really focused on a different population of patients. So much like in the metastatic advanced disease setting, patients with driver mutations or gene rearrangements that have approved targeted therapies, it's preferable to give a targeted therapy agent in that subset of patients. And we're seeing that echoed in the earlier stage patients, particularly in the EGFR ALK positive patients, where those patients really should go onto a targeted therapy agent. ADAURA trial, which was adjuvant Tagrisso, Osimertinib, in resected stages 1B to 3 patients. Impressive DFS data, and these are patients that have activating EGFR mutations. Those patients really should get Tagrisso in the adjuvant setting and not immunotherapy, despite the IMpower010 results, because those patients have a driver mutation. So it's really about the appropriate population. On the other hand, in the absence of a driver mutation, patients should really be evaluated for chemotherapy, and particularly in the neoadjuvant setting, it's what it appears to be that where we're headed is the combination of chemo and IO in the neoadjuvant setting. We need to see the other Phase III trials. There are currently 6 Phase III trials addressing chemo IO in the neoadjuvant space. All of them have an adjuvant arm to the trials, except for Checkmate 816. So how the adjuvant IO alone fits into that space following neoadjuvant chemo IO, we're waiting for the other Phase III trials to read out to see how that fits. But honestly, how targeted therapy and immunotherapy is fitting into the early stages very much dependent on absence or presence of driver mutations.